Okay, so welcome to our season two, episode two of Optical Health podcast. We are discussing today vision correction surgery, the perception of safety, and our collaboration with our wonderful optometrist colleague and eye surgeons. Our special guest is Trusit Dave. He is well known to be an educator, innovator, and optometrist, expert optometrist in his field. My name is Tina Khanam, your host. I'm an eye surgeon in London and director of K Vision Centre, the Optical Health Centre. So welcome, Trusit, to our podcast. We hope our conversation will be educational and of benefit to our listeners. So how are you today?
Thank you. Thanks for the invitation, Tina. I'm very well, thank you. The weather's not quite as glorious as it is in London, but here we are in a beautiful Warwickshire.
Excellent, excellent. So let's start by talking about the perception gap. I find that some optometrists, or a lot of the optometrists, view vision correction surgery as unsafe, or they have concerns about it. Is that your experience in your conversation with your colleagues, or your personal feelings?
Right. Well, I didn't quite expect to get so thick into it, but that's fine. We can get right into the thick of things. I think it's kind of in terms of vision correction, and the perception that they have. I think a lot has got to do with what we in research would refer to as kind of sampling bias, really.
Hmm.
Um, if I kind of reverse that entire question to you as an
Yeah,
ophthalmologist,
yeah.
would you think contact lenses are safe?
So contact lenses are a great tool to start
Hmm.
with, but as we have shown in our in research before, that if you wear contact lens for a whole year, you would have taken the same kind of risk as having vision correction surgery. So definitely that's your lower ladder. So you start with a contact lens, see how patient feels, and then you can ramp it up and see if that suits their needs, or if their safety profile is it's better dealt with just contact lenses.
Yeah, I guess I really wasn't after the stats there. I think what I was trying to allude to was
Yeah.
it's like the perception gap is what you specifically said, right? So it's not so much about the science, but it's about what you feel and where do
Yeah.
we get our gut feelings about how safe something is.
Yes.
I think those gut feelings come from where we've worked, the environment that we've worked in.
Yeah.
And that gives us that sampling bias in the sense that, as a doctor, you've worked in eye casualty, right?
Yeah.
So you've therefore inherently been subject to seeing a lot more people who come in with Pseudomonas, acanthamoeba, as corneal infections.
Yeah.
And so your take home point is contact lenses are not healthy, right?
Well, I do. You're right.
It
I
could be.
see the extreme spectrum of lots of people presenting with contact lens related infection, but
Yeah.
I do value the importance of having contact lens in your array of treatment. But is just what do you think? Because the optometrists won't be delivering vision correction surgery, their perception gap will, again, like you said, will hone from what they're exposed to. So
And exactly.
they may have been exposed to ophthalmologists and eye surgeons who don't do vision correction surgery, hence have that perception gap that they pass on, do you think?
Well, I think it's again, we've got to look back at what optometrists then in their environment. So obviously, if you're a surgeon and you spent all this time in casualty and you think contact lenses are unhealthy, that's a misconception
Yeah,
because there's lots of data on, the benefits of contact lenses and the safety profiles of them, right? And you've already discussed that.
yeah,
Um, an optometrist is exposed in their practices to quite a few historic things. So if you go back, I mean, I'm pretty old, so I've got 30 years of practice
yeah,
at the moment. And when we start looking back at the arcades I used to see,
yeah,
okay, if that is my interpretation of refractive surgery, I'm
yes,
going to have a negative impact. If I look back at pre-femto refractive surgery correction, keratome corrections, and
yeah,
I looked at the regressions that we got,
yeah,
and if that was my basis of conclusion of refractive surgery, gosh, I'd be out of date.
Yeah.
Okay.
Yeah.
Modern day femtos, smile, all these kind of refractive innovations
Yeah.
have led to considerable improvements, right? So we don't get as anywhere near the regression that we used to get earlier. So things like nerve damage has been reduced, dry eye is reduced, and it's temporary rather than, well, most of it is temporary. But again, so keeping abreast is important, and talking to your colleagues is important to reduce that perception gap, right? So I think that's really, really critical.
Yeah,
Um,
right. We've come
and
a long way, haven't we? Because the days of our case in 40 years ago and 30 years ago, it's complete different environment and scenario to what we've got today. So we've got your PRK, your LASIK, your lenticular extraction and ICL, which are much more safer and have 3-4 decades of safety data with them. But yeah, you're absolutely right. Our case done a lot of damage to refractive surgery and the vision correction
but
perception of the
but
data.
also, yeah, but also kind of, forgive me for saying that in the early days, the patient selection
Yeah,
wasn't always done as well as it ought to be.
of course.
So, you still see patients who like are minus nines that have had a surface laser procedure. Now, I'm sure there's going to be some ophthalmologists out there who are
Yeah,
going to disagree with me and say, well, you can do them. And I'm not talking about those extreme cases, but I've definitely got cases where there's ectasias now, and there's been maybe a little bit of over enthusiastic treatment, shall we say.
yeah,
So, and I've kind of come back again. I have to temper myself. So,
yeah,
I run a really strong dry eye service in Warwickshire.
yeah,
So again, I've got a whole heap of patients coming in,
yeah,
who come in, some with kind of nerve pain,
yeah,
some who have had were kind of originally a minus nine, and you
mm,
can literally see the tear film break up in an annulus, and you sort of know it's a mechanical issue to do with the corneal profile now, and that's causing a lot of dry eye. But I also get a lot of other patients who come in who have got dry eye for purely natural reasons, who have had laser refractive surgery, and they just want to blame that, or they've been told by somebody else, another optometrist, that it's because of their refractive surgery, and
yeah,
clearly it isn't. So,
yeah,
we've got to be duty bound to kind of temper everything and use our abilities to interpret things properly,
yeah.
before we sort of just naturally ally cause and effect.
Of course, yeah. And we are very good at labeling and putting things in boxes, but real life doesn't work like that, just as you highlighted. So we did talk about a little bit about evidence-based safety for modern day vision correction surgery, and the many decades of safety data that we had, and the many innovations that's come along the way, and has improved patient care and patient outcome. Do you feel that the optometrists are aware or are making an effort, or we are getting through to them that these are happening and has happened?
I like that question. um, so I think optometrists are aware of, that it's drilled into them, what the contact lens safety profiles are. Okay, so, and primarily because they're all fitting contact lenses, right? So they need to know that when they're consenting their patients. So when it comes to laser refractive surgery, I think that data might be not as, they're probably not as clear on that.
Yeah,
It's I mean, there is a gap there. The issue is, how do you get an optometrist to be competent in all of these things? And I think the same gaps exist in an ophthalmologist who's not a refractive surgeon. So when you talk to your glaucoma and VR colleagues, you probably have a similar challenge to talking to an optometrist, I would imagine, right? I can see by that smile on your face, maybe that's the case. Um,
exactly. Because I've just had this week actually a A&E nurse whose partner works as an ophthalmology nurse, and she has been talking about his vision correction surgery to non-vision correction surgeons, and she's been, the fear of God has been put in them, and they're staying away from vision correction surgery. So yeah, we do have perception gap in those eye surgeons who don't do vision correction surgery. Absolutely.
And I think it's nobody's fault. It's kind of like how much can you teach? So when you've got an optometry student who's got a 4 year degree program, 3 year degree program, then professional exams, and it's kind of close to 5 years now,
Yeah,
then the regulatory bodies say this is what you need to be competent. And if you think about the same optometrists now, and a lot of the universities, even rigid gas permeable lenses
yeah.
teaching is not on the syllabus,
Wow,
right?
really? Okay.
So if
Yeah,
you think about specialty lenses like sclerals, and you'd think that would be in the realm of an optometrist,
yeah,
but it's not because it's not being taught at universities. So do you think they're going to be talking about complication rates and understanding risks and benefits of refractive surgery?
yeah,
It's not going to happen. So I think that they're certainly talking about those as options, and the surgical options are being taught at universities,
yeah,
but the depth that we're kind of talking about, so that you could go in with a patient and have that open discussion,
yeah.
probably is not going to be to the way you would want it to happen, or the way I would want it to happen.
Of course, of course. And, so let's categorize the optometrist and their knowledge and clinical base. So the young ones, you just spoke about the young ones coming through and their educational program. But the older one, do you think the older ones, because they've had, like yourself, been exposed to RK and their complication, do you think they're more protective of overly protective of their patient from vision correction surgery, and rightfully so?
Um, Look, I think it's when we start talking about we're almost talking about the ethics, I guess, of being protective or not being protective.
Yeah,
There's a number of things, really, aren't there? I mean, we don't want our patients. Any surgical procedure's got risks.
yeah,
Contact lenses have got risks, okay, but it's kind of what is it that our patients want,
yeah,
and it's about understanding how our patients feel. It's about understanding what their needs are and what their frustrations are.
yeah,
And sometimes it's not about it's about giving them the options and
yeah,
understand where they are in their life in terms of what they need to do.
yeah,
And a lot of my patients, even when I give those options, they're not always ready to jump at refractive surgery. For some of them, it'll be 5 years later that they'll take that plunge, but at least we've discussed it.
yeah,
My other colleagues may not. I mean, I think it's so much more complex than just age profile of the colleague. I think it's where they've worked,
yeah,
what commercial pressures they've got on them. The vast majority of optometrists work in high street retail environments,
mm,
right? They're owned by big business. Um, I mean, what pressures are on them?
yeah,
If you were employed by somebody whose fundamentally KPIs are how many glasses and how many contact lenses are being dispensed, right? If that's their business model,
yeah.
and as an optometrist, you're kind of going out saying, here are all the options, and let's talk about your needs, and do you think your kind of line manager is going to be?
Yeah, true. You're right. The commercial pressure is a real factor, isn't it, in this case? And do you think that's kind of drives the unspoken competition between selling glasses and contact lens compared to sending people to or patients to eye surgeons for vision correction surgery?
Um, I think if patients really want to have treatments like that, they're going to find them.
Yeah.
I think if as an optometrist you're not talking about it to them, you're going to lose them anyway.
Uh,
So, and you've not done the right thing by your patient. So, I'm generally so my personal view is I'm very open at discussing it because I want to be the gatekeeper for that.
yeah.
And I know more about my patient than an ophthalmologist is going to, because their job is to operate on them, and they really don't want to see them again, because if they're having to see them again, that means there's a problem in general. Because of all those things, I help them choose the surgeon, and generally the surgeons I've got the most experience in working with.
Yeah.
So that's what's important to me and the patient.
Yeah, it's absolutely right. Optometrists will know their patients well, and they would have seen them throughout their journey from the beginning. And we do borrow your patients. So, when they come to us for consultation and surgery, we borrow them for a period and then we send them back to you. So they are your patients. And we do recognize that trust and connection that you have with your patient and how that influences their decision. So a lot of patients do value, and most of the patients value what their optometrist is telling them. So if they're having that conversation, as well as glasses and contact lens, it really does drive their decision making. Do you not find?
I mean, I think there's a lot of collaboration that's to be had there. There's so much in terms of a lot of optometrists now are IP trained, they're subspecializing, they're doing glaucoma diplomas, they're doing the IP training, and maybe they're interested in refractive surgery and dry eye. So there's a lot of overlap there where together, particularly if you're working with someone who specializes in dry eye,
Yeah,
there's no reason why you wouldn't want to have some refractive procedures and recommend those, because you're also going to be working with them to manage other problems, and maybe you could deliver on those other premium treatments in the optometry practices. So I think there's a huge scope for working together.
yeah, excellent. I think that's where the collaboration will work because, there are, apart from the vision correction surgery, like you said, there are opportunities for the optometrists to drive their dry eye treatment packages in the community. And that's where the role of leadership comes in, and that's where we can bridge the gap to really address patient needs. Is there any other thoughts you had how we can bridge the gap of the perception gap we talked about?
Well, I think there's so that we've got a whole group of kind of high-end independent practices,
Yeah.
right? And I think the perception gap is a slightly different question. So I think I'm going to stick to that because I think we can come back to that segment maybe later in this discussion. But the perception gap for me is about getting optometrists engaged. Okay, so and there are ways and means of doing that. So one might be as an independent surgeon yourself, you reaching out and engaging with optometrists. And I know you do a great job on that already. But then there's also societies, like, for example, the BSRS recently had a really successful conference, and they're very, very open to working with optometrists and having them at their conference, wet labs and things like that, where optometrists can try doing a bit of refractive surgery. I think all of those things are really, really will help. Yeah, for sure.
Brilliant. Yeah. So more collaboration and engagement, and I think that face-to-face interaction between the two professions really helps to collaborate together and bridge that gap, as you said. Uh, I think it's important to have a unified message between the two sectors, so patients don't get confused, and they, as you said, the optometrists are better at knowing their pain points and knowing where they're at in their life, and we have a unified message, we can serve them better. What would you say?
I, I think I think it's first of all starting from the very basics.
Yeah,
If we start looking at risks, let's talk about the definitions of those risks, right? So, both procedures,
yeah,
right, are safe.
yeah,
Yeah. Refractive surgery, contact lenses are safe. I don't think it helps when I've heard ophthalmologists go around saying, don't, contact lenses are unsafe. Yeah, I've heard that. I've heard some friends of mine who are ophthalmologists, refractive surgeons, who we'll have an interesting discussion, and we'll be together, and we might be having a drink together, and I wouldn't put a contact lens in mine. I'm like, why?
yeah, yeah.
The risk profile is really, really low, two to
That's a
five
great,
per 10,000 a year, right? Okay,
it's a great
and
innovation, isn't it? It's a great innovation.
absolutely, and it's only getting better, and the safety profile's only getting better. So the consumer awareness is there, the safety profile is there. I think, when you look at it over 10 years, 20 years, of course, it's not like a single incident like refractive surgery. So I think probably refractive surgery has got the edge in terms of safety. I would agree with that. But when you look at the risk, it's still low, right? So I think both of us have to start saying, look, these are both safe procedures, and it's what's right for you in your timeline. Okay, so when it's right for the patients, they just need to know that there are options available.
Yeah.
Yeah,
That's all they're coming for. They're coming to your expert advice of what is out there that can help them. So that's
exactly.
our duty to tell them the whole gamut. That's it.
Exactly. So it's the worst thing that you can do is say, "Oh no, don't consider laser refractive. It's dangerous. It's not. I wouldn't have it." That's completely wrong. Likewise, for somebody who is, spent most of their time seeing patients with corneal problems and those induced by contact lenses, you have to kind of step back and say, "Is it because I've just seemed to be seeing those in the sample that I'm getting, and therefore the reality is data tells you." They are safe. So that's the first thing, a unified message that these are very safe options for our patients. And let's just tell them that, these options are available to you now. So when is it right for you to consider it? And obviously there are age restrictions for refractive for surgery. So I mean, some surgeons would say 21. I tend to say to my patients, well, I would kind of go a little bit after 21, maybe sort of 23, 25, if you're having a refractive procedure, mainly because, we want that RX to be as stable as possible. And by 21, particularly if you'd like talking about myopia, around about 90% are going to be stable by that time. So that's why I kind of go for a little bit later, especially with the adolescent development in higher education. So I tend to go a little bit later. But yeah, I mean, and then
I do say 21, and it has to be stable 2 years prior to that. So, if there's no really cutoff. So if at 21, they're still not stable for the past 2 years, then yeah, of course, wait till 2022, 23. That's absolutely fine. But yeah, but it's
I was going to say, do you find that if they're in kind of higher education and studying a lot more, would that influence your decision in terms of going a little bit later?
Yeah, because you do get academic myopia.
Yeah.
So, they're working at short distances and reading a lot and using their computer a lot, not being outdoors, and all of that matters, as we know, for myopia especially. So, yeah, that education is very, very true. And, we need to educate patients that they need to spend time outdoors, relax their eyes and look in the horizon, which is difficult in parts of London, but, find those opportunities to really relax the eyes. And these are still growing and modifying organs. So
I like the term academic. What do you say? Academic myopia.
yeah. So
I prefer adolescent myopia.
that's the
What,
minus one.
what if you're not an academic and you're getting myopia? So yeah, adolescent myopia.
Yeah, no, but yeah, I think the term I picked up from is for those uni students who were fine, ametropic, and then they become a bit minus one or because
Yeah.
of bookwork. But yeah, we can use both terms. It just
Yeah.
depending on the context. If they're in uni, then we call them academic myopia.
Academics. True.
So yeah, so we are living in a really exciting time. There's so many things happening. Even ICL got so much more safety profile, and we can treat such an array of astigmatism and such bigger myopia and hyperopia. So things are really good, in a good place for patients, and we need to be positive to our patients that these are available to them, and there are lots of hope for their vision to be better and clearer.
I think ICLs and implantable lenses are amazing, and we are pretty proactive in recommending them. I think as an optometrist, you only need to kind of look at those patients who have got very high levels of ametropia and the quality of life, potentially mental health even.
Yeah.
I mean, it does affect people. you know, we might say contact lenses. But if you're, I always use this example of this patient of mine who's a dentist, and I think it was about minus 24 in his glasses.
Yeah.
And I remember he'd come to see me. We got him straight into, actually, he was already wearing soft lenses, but they were so thick, the soft lenses. He had some early neovascularization, so took him out of those. And then we put him into GP lenses, and I saw him walking, and he just walked past me when we were dropping the kids off at school. And it's because he was so scared of these little things flicking out of his eye. And immediately we kind of rang him up the next day and said, look, just come in.
Yeah.
And we got him to have ICL,
Yeah.
and it really did transform his life. And he's never looked back. His confidence has just changed. So
Oh,
it is.
no, it's such a transformational, so the outcome is such a transformational experience for patients. So it's brilliant. Just one last point. I know
Hmm.
from my LinkedIn post that a lot of people engage with this. Patients will come to you and say, look, you're talking to me about getting Apple glasses and these are available. How come you didn't take them up? You're still wearing glasses. Do you get that from your patients?
I do, and I tell them that I have been for refractive consultations.
Yeah.
And I'm not sure I can mention the surgeons that I spoke to, but they're good friends of mine, and we've discussed having elective surgery. I mean, basically, I've been talking about it for so long that I've gone from one age classification to another, where previously it was an ICL that I'd considered,
Yeah.
but now that I'm in my 50s, it's kind of like, nah, let's go for a lens exchange altogether. So now I'd be considering that, and it's just a matter of time, really, because I've got about 4.5 diopters of astigmatism with a little bit of hyperopia. So kind of thinking about full correction, and most of the surgeons that I've spoken to are like, oh, I'm not sure I want to be your surgeon.
But
So,
no, seriously, if you have it done, you'll be a new man, Trusit. So yeah,
thank you.
yeah,
I will. I will. And I'm seriously contemplating on having it done. I would love to, because at the end of my clinics, there are two rings around my glasses, and
oh,
it's where the slit lamp has been left imprints on my glasses. So yeah, I'm a frustrated spectacle lens wearer for sure. So yeah.
yeah. Thank you for Trusit for being so honest and describing your experience and how we can help patients together. And we've really enjoyed having your discussions and your wealth of wisdom because you've been in the market for a long time. You've experienced a lot of things. You've gathered a lot of knowledge, and I'm hoping listeners will be of benefit from listening to our conversation. Is there
Uh,
anything else you'd like to tell our listeners before we end?
Well, no, I hope you've enjoyed it, and I think, Bettina, this podcast is fantastic. So I've watched your other episodes, and I think let's keep continuing. And the more collaboration we have together, and the more discussions like this, the better it is. And I think just people listening to it will make them realize that we're kind of aiming to help patients. That's the only thing that's important here.
That's it. We're on the same page. We're here to help our patients. So thank you very much. And we've
Thank
really
you.
enjoyed it. Thank you for tuning in, and we'll see you for the next episode. Thanks, Tris.
Take care.
Take
Bye
care.
bye.
Bye now.